those are things which should be ticked off in your list. Unless you have all those points in your list, your history is not really complete. And then in the physical examination, vital signs are very important. Again, it is very important to check in a diabetic patient who may complain of dizziness. It is very necessary to check the BP in the supine as well as standing position to see that you have not missed out on a simple thing like orthostatic hypotension. To give you an example, and look for presence of bruise and other abnormalities, especially carotid in the neck. Ear examination, a simple ear examination to see if there is a discharge, whether there is any mastoid problem or tenderness, which will point to a peripheral vestibular problem, inner ear problem. Eye examination and positional testing. Now this is very, very important. I will show you a few slides of certain tests that we usually do. And lastly, neurological examination, which includes gait. At this point, I would like to change and just want to change the presentation here. Yeah, among the positional tests, the commonly done tests, easy to do. These are all the bedside in your own clinic. You don't need any sophisticated equipment other than your own brain to interpret these tests. This everybody knows the Romberg test. Romberg test is not only for cerebellar disease and sensory ataxia as most people think, but it will also give us a clue for vestibular disorders. So with the eyes closed and feet together, patient tends to lean to one side, which may often be the abnormal side, and this gives a clue. And this will not be, for example, if you look at a patient with sensory ataxia, cerebellar ataxia, even with eyes open, they will become unsteady. With sensory ataxia, the moment they close eyes, they become unsteady and they tend to fall. Whereas with vestibular diseases, when they close their eyes, they will not have an immediate abnormality unless the vestibular disease is very severe, but slowly they will tend to tilt to one side and then they will try to correct themselves. Now this is because again of the illusion of movement which the brain tends to correct. The next easy test to do is the Unterberger test, or what I call the step test, in which the person is made to stand like this with his feet together and they are told to do something like marching on the spot with knees going as high up as possible, and then to continue it with their eyes closed, and slowly you will see what happens is they will start turning in another direction with their eyes closed, whereas a normal person usually does not do that. So this is another sign of a peripheral vestibular problem. And pass pointing, of course, many people know, with eyes closed they will start, their hand starts drifting. And the star walking or the Babinski-Weil test, in which a patient is made to walk 5 steps forward or 5 steps backward, and with eyes closed they will start wandering. They will not walk in a straight line, they will start moving in different directions and zigzag patterns. These are 3 or 4 very simple tests that we usually do. So it's going to the first one. So like I said, we come back to the completion of the examination. So based on the history and examination, you can form this diagnostic matrix. Like I was saying, it is very simple. Whether the vertigo is episodic or whether it is persistent, whether it is associated with hearing loss or whether it is not associated with hearing loss. Based on this, we can fill in each of these squares with different disorders and it becomes easy to diagnose. So this is an acronym which we can always remember, which is very easy because the name itself is related to the disease. SPIND, which differentiates between the peripheral and the central vertigo. So first we will concentrate only on the peripheral. It is always sudden in onset. There is always a positional change or a positional aggravation. The intensity is usually very severe, and nausea and vomiting, that is other associated sympathetic or autonomic disturbances, are very frequent. Nystagmus is almost always torsional or horizontal. This is very crucial to remember. This is a very important clue. If you find any element of vertical nystagmus, never think of a peripheral lesion. It is always central. And hearing loss, presence of ear symptoms, hearing loss can be present. In central disorders, usually you do not find acute hearing loss. Duration may be acute, brief, or it may be paroxysmal, it may come and go. Again, central, we usually say it is constant, but when you have recurrent TIAs, it may come and go, but you have to look for other presence of other neurological signs at that time. And of course, in a central, the CNS signs will always be present. Always, when you do a proper examination, you will find some telltale sign of a CNS disorder. whereas in a peripheral it will be absent. Therefore, one rule of thumb that we can always remember, when you have a monosymptomatic vertigo with no other, when you are absolutely certain that you do not have any central signs or symptoms, you can be fairly certain and confident that it is a peripheral vertigo. So, what are the, we will go into this in brief now. Approximately 85% of patients who come to you with vertigo are due to peripheral diseases and due to dysfunction of one vestibular system. There is always, it is because of an asymmetry of input from the two sides. There is always a sensation of rotation and associated nausea pallor. So, this is a summary of what we just saw. And what are the differentials? So, BPPV forms the bulk, it is benign paroxysmal positional vertigo. The other ones are vestibular neuronitis or neuritis, as some people like to call it, labyrinthitis. Some specialists differentiate between labyrinthitis and vestibular neuritis, whereas some tend to clump them together. We will see what is the difference between the two. Other disorders like Meniere's disease, sometimes infections, perilymphatic fistula because of trauma and so on. So, when you come to this diagnostic matrix, now it is easy to see that no hearing loss, episodic, frequent, coming and going, that fits benign paroxysmal positional vertigo. So, what is BPPV? Each letter in this acronym is highlighted here. There is no specific age band. It can be seen in most age groups except children. Children are resistant to this particular disorder, and head trauma may sometimes predispose. So, what is the characteristic story here? You turn head, after a few seconds delay, vertigo may occur and resolves within a minute if you do not move. So, if you move the head in this particular direction or in a particular direction, you may experience vertigo. If you hold it in that particular direction for a while, the vertigo will disappear, and if you turn the head back and come back to the original position, again the vertigo occurs, but this time it is in the opposite direction. But very often you will find that patients do not give you such a very clear history. You may have to go into it in detail, or you will find it when you are actually examining the patient. So, there are provocative maneuvers which we will be seeing. So, as you see, these slides highlight each individual letter. Benign, B stands for benign, because this was highlighted to indicate that this is not a malignant disorder, it is not something which is dire or life threatening in any sense, but it is definitely incapacitating to most patients. P stands for paroxysmal, that is episodic, it comes and goes, it is not always there, it is not persistent. So, sometimes people say it is not, it is paroxysmal, and that is a helpful feature in the diagnosis. So, when there is a history that there are clear cut episodes with a starting and ending, and in between these episodes patient is absolutely normal despite being in provocative positions, it is a clear indicator of positional vertigo. Positional, that is, occurs with particular positions which are aggravating, turning over in bed or looking up, bending over and so on. And V, vertigo. Now, this again, there has to be the illusion of movement. So, BPPV, all letters are covered, and that is what it is. So, what causes this BPPV? It is because the otoliths that we saw, which are present in the utricle, they become detached from the hair cells, and they inappropriately enter the posterior semicircular canal. And what happens because of that? And because of that, what happens is, before that we see what happens in a normal situation. As one turns the head to the right or to the left, there is a movement of the endolymph in the semicircular canals. The receptors fire saying that the head is turning to the right. When you stop turning, the endolymph stops flowing, the hair cells stop moving, the impulses to the brain stop, therefore the brain knows that the head has stopped moving. Whereas, what happens here is, even though you stop turning the head, because these displaced otoliths or the floating debris, they keep moving, and therefore they drag the endolymph with them to very short distances. Therefore, in spite of stopping the head, the endolymph is still moving, it inappropriately stimulates and sends impulses to the brain saying that the head is still moving, but the eyes say that the head has stopped moving. So, there is a conflict of information to the brain, and therefore the brain interprets it in a totally different manner, thinking that the room is spinning in the opposite direction. So, that is why there is this illusion of movement. So, what do we do to either provoke or to find out whether it is BPPV? It is generally from the history, but we can do this to confirm the diagnosis, that is the Dix-Hallpike maneuver. It has other names as well, and the main points to remember are that nystagmus appears in the provocative position only. When you make the patient sit like this and look for gaze evoke nystagmus, it will not be there. You do this, you make the patient sit in his chair in your clinic and ask him to look to the right or left, up and down, and say there is no nystagmus. No, wrong, that is not acceptable, because in this position nystagmus will not be there, and therefore you will miss it. So you will have to put the patient in that particular position and examine, and then say whether it is there or not, which again will help you to diagnose other conditions when it is not there. So there is always a brief latency to symptoms. You will have to wait for a few seconds before the nystagmus appears, before saying that there is no nystagmus. And the duration of attacks are very short, and if you if you continue to hold the head in that position, the attack will stop. And when you do it repeatedly, there is a fatigability. So if you do it 3-4 times, the attack will, the intensity of the symptoms and the intensity of movement of the nystagmus also will gradually fade, and it will stop. So this shows us diagrammatically. This is a patient. You make the patient sit, and then bring them down with the head hanging below the edge of the table, and tilt it either to the right or to the left, and hold it for a few seconds, 10 to 20 seconds, and then you will start to see the nystagmus as it appears. Are lab studies really required in straightforward cases? No. When you make a diagnosis which is paroxysmal, brief, no auditory symptoms, no other neurological findings, and you do the Dix-Hallpike and you find that there is a positional aggravation, nothing else is required. You have a diagnosis. Maybe in certain situations when you have other precipitate or when you have other underlying factors, you may have to do certain basic investigations. If the person has prolonged vomiting because of this, you may have to do certain metabolic investigations. Other than that, nothing specific is required in these cases. So what is the treatment largely is manipulation, that is non-drug therapy. It was first, the Epley maneuver was first described in 92 by Epley. It's a simple bedside maneuver, and it provides immediate relief, and he initially reported an 80% success rate, that is 4 out of 5 patients will experience remarkable relief in their symptoms and signs for a prolonged period on performing this maneuver. But over a period of time there tends to be a recurrence, because the debris again starts to float back into the posterior semicircular canal, but this has to be done properly. And randomized control studies also showed remarkable success. So this, and it provides lasting relief to patients rather than going on taking medicines. So how do we do it? It is also called the canalith repositioning maneuver. The name is self-explanatory. So all this debris which is now circulating or free floating in the posterior semicircular canal is taken out and brought back into the place where it belongs, that is into the utricular region. So it is a 5-step procedure. And so what we do is, first we do the Hallpike and find out in which particular position, whether to the right or to the left. In this head hanging position the vertigo occurs, that is the starting position, and then you turn the head by 90 degrees to the other side, and then the patient is completely rotated over onto his shoulder and the head facing the floor. Now this will show us how it actually occurs. This is the patient in the sitting position before you start the maneuver. These are the free floating the debris in the posterior semicircular canal, as you can see now. This is the beginning of the Epley, and you have turned the head over by 90 degrees and it moves this way, and you rotate the patient on his shoulder, it comes back into the mouth of the utricle, and you make the patient sit up, it goes back into the utricle where it belongs. So this is how it is done. It may be repeated if necessary, and repeating it gives better results. Post procedure, the patient is always advised to remain upright for up to a day or so that it doesn't worsen or produce other symptoms. Now what are the contraindications? It should not be done in patients with unstable heart disease or high grade carotids, where you keep rotating or manipulating the neck, which may cause other dire complications, or when they have severe cervical spondylosis or past neck trauma and other such conditions. Of course, now this need not be overemphasized. When there is an ongoing CNS disease like a TIA or stroke, you would not even think of doing this maneuver, and other situations like pregnancy. So what are the complications? It may aggravate symptoms like vomiting. Sometimes what happens is, from a posterior canal BPPV, it may be converted to horizontal canal BPPV, and the patient is none the worse for all that. So sometimes when this may not work, or if you are not able to do this, lighter exercises can be prescribed for this patient. These are the brand of exercises which you can teach them. They can do it at home themselves, which is similar but not as intense as a play maneuver. And then we come to the drug treatment, mainly vestibular suppressants to prevent other symptoms or suppress the other symptoms. Meclizine is used, but now by and large beta-histine is the mainstay of treatment because it has very few side effects, it does not interact with other medications. If the patient is on other medications like cardiac drugs or anti-diabetic medications, antihypertensives and so on, or if he has other underlying neurological disease, this is a far better choice. And most important is that it does not interfere with the vestibular rehabilitation, which most of the other drugs do, and therefore nowadays they are not really recommended. Dimenhydrinate or Gravol and diphenhydramine, these have all been they are to be used only symptomatically and for brief periods to give relief to the patient from symptoms like vomiting. And benzodiazepines, this is I am mentioning only to emphasize that they should not be used in acute cases except when the patient has other symptoms of overlay, like for example psychological overlay or anxiety or severe panic attacks, in which case they may help. Other than that, they should not really be used because they tend to drag on these attacks, they suppress the entire system and they prevent or prolong rehabilitation, and therefore it is better that we do not use benzodiazepines. And as you can see, vast majority of peripheral vertigo can be managed conservatively, and any form of surgical intervention or ablation therapy is really required only for very severe cases which are very protracted and do not respond. So the next in this matrix, as we can see, is when there is BPPV is without hearing loss, but again when it is episodic and with hearing loss, it is Meniere's disease, the common one. Symptoms are the same, but they tend to be more intense. The additional symptoms, as everybody knows, is that they have tinnitus, hearing deficits, which may tend to become worse with each attack over a period of time. It relapses. There may be a family history as well, and usually it is conservative treatment with vestibular suppressants. This figure shows you this is a normal labyrinth as against the other one with endolymphatic hydrops here with swelling. Sometimes even diuretics may be used to reduce this. And then the last part of the matrix, you have persistent symptoms. So persistent, now this is where the difference comes up between vestibular neuritis or neuronitis and labyrinthitis. When it is with hearing loss, that is the entire labyrinth is affected, both the cochlea as well as the vestibular system. Some people call it labyrinthitis, and when it does not involve hearing, it is called vestibular neuronitis. Symptoms remain more or less the same except for the additional involvement of hearing, tends to linger over a period of time, but still it is self-limiting and may follow other infections, viral infections, respiratory infections and so on. It is also worsened by head movement. Now the point to remember clinically is that this also is worsened by head movements, occurs in young, otherwise previously healthy young to middle-aged people, but the positional testing or the provocative tests are negative because it can occur even when you just shake the head like that, it can provoke, whereas in BPPV only particular positions or particular maneuvers will provoke. So this is the difference between the two, and therefore you will have to differentiate between vestibular neuronitis or a neuritis versus a BPPV. And this is again, this is not a very common situation that we see in day-to-day practice, but it can happen after a forceful cough, sneeze or diving and or a direct blow to the ear in short trauma, but it is a self-limiting condition. And then these are some of the common things that we see which are the causes of peripheral vertigo. Now we come to central vertigo, that is which are produced by the central structures which we saw earlier, and this may include disorders with significant potential morbidity and mortality, and this definitely, this group of disorders when we see or when we encounter, this definitely warrants indication or initiation of further workup. So again we come back to this acronym. Here you can concentrate on this half of the chart, that is positional. There is no positional change or positional predominance here. It is only TIAs or strokes may have a sudden onset, but usually they are by and large gradual. intensity may be ill defined. For example, in a lateral medullary syndrome or a Wallenberg syndrome, the symptoms may be very intense, but they will invariably be associated with signs, that is dysarthria or sensory signs and lateropulsion and so many other neurological signs. Vertical nystagmus will be present in a central disorder. Usually hearing loss is absent. So that is how we differentiate between central and a peripheral disorder. And what are the differential diagnoses? Obviously, depending on age and other characteristics, vascular disorders, vertebrobasilar circulation events, TIAs, cerebellar hemorrhages, like I said, lateral medullary syndromes or Wallenberg syndrome, very common. Vertebral artery dissections and other differential. Now the last group also is very important, migraine. Migraine is a very important differential because a large part of practice consists of migraine, and a subset of population of patients with migraine do experience periodic vertigo, and this is usually associated or followed by the headache. So it may fall under the category of migraine equivalence, especially in children, or migraine aura, which is seen in adults, and this may present with the typical rotatory symptom or a feeling of lightheadedness or dizziness, which is followed by the headache and vomiting. And post-concussive syndromes, tumors, etc., which are surgical. Multiple sclerosis, yes, it can present with recurrent episodes of vertigo and other brainstem symptoms. And in infections, last but not the least, even degenerative disorders like Parkinson's disease can present with ill-defined sense of disequilibrium and vertigo, which may be a mixture of both, and this is easily diagnosed by the presence of overwhelming neurological signs in the form of rigidity and other findings, which helps you to come to the diagnosis. And neuroimaging. Now when do we do neuroimaging? Obviously when we suspect only central disorders, when there is a headache which is sudden onset or severe, hard neurological findings, and no imaging for patients with no risk factors. An exam suggestive of peripheral vertigo, you do not need imaging. So this is just a resume of a study which showed that 24 patients with risk factors for stroke and a history of vertigo for about 48 hours and normal neurological examination except nystagmus. Nystagmus obviously will be there in a peripheral and a central lesion, but surprisingly 25% of them had inferior cerebellar infarction. This can present as a true vertigo. Another condition which can present only with vertigo is when there is an isolated block or a lesion in the cochlear artery which goes to supply the vestibule, and if there is an infarction in that region alone, it can present only as a peripheral vertigo, but it will usually be associated with acute hearing deficit. So that's how it helps you to differentiate with appropriate risk factors. So CT versus MRI, which is useful? MRI for obviously for demyelinating diseases, vascular diseases, tumors of the brain and so on. Only when we suspect a hemorrhage, CT is more sensitive. And important thing is, negative CT does not always mean that we are automatically dealing with the peripheral vertigo. CT tends to miss a lot of lesions, especially things like demyelination or small brainstem strokes or small ischemic lesions in the brain will be missed by a CT. So other investigations, audiometric evaluation as and when